Hi, I'm Matthew Price, interventional cardiology from Scripps Clinic in La Jolla, California, speaking here from TCT, where we've presented a lot of data about coronary intravascular lithotripsy, including some interesting OCT findings and one new data from the Disrupt C83 trial that led to the approval of coronary IVL in the United States. I thought I'd walk through some pragmatic approaches to using IVL in complex lesion subsets, including lung disease. So here, we can talk a bit about pragmatic predilatation. So when is a reasonable time to pull out coronary IVL in the cath lab? So first, if you have a device that can cross a lesion, like a balloon, okay, you can either image up front, or you can try a non-compliant balloon to see if you get good expansion of the lesion, which should predict good stent expansion. If you do not have good expansion of non-compliant balloon, there's a waist, you don't reach the full diameter of the balloon, there is when you know you can deliver a device. That is when coronary IVL may be most suitable in this pragmatic approach. After shockwave IVL, you can consider imaging to optimize your PCI and make sure that you have a good result, or you don't have to. You can continue to post-dilate and see if you get a good result. So let's walk through this sort of pragmatic approach in a complex lesion. So this is a 76-year-old female with class 3 angina with multivessel disease. You see this first on the left, a very severe proximal LED lesion. You can see fluoroscopically before contrast is administered, there is calcium on both sides of the vessel that extends certainly more than 15 millimeters. I would say offhand here is about 25 to 28, even 30 millimeters of calcium from nearly the offset LED down to that first diagonal. And in the caudal projection, you see a highly calcified bifurcation lesion involving the first OM and the ongoing circumflex. So we focus on the LED, that LED lesion alone. That would be a type of lesion that would have been enrolled in the Disrupt C83 trial, although it is pretty complicated, but it does fit that criteria. On the longer aspect would be a longer lesion in that trial. So how did I approach this? Well, first, I didn't think I could get an imaging catheter down initially. I'm a big fan of imaging, intravascular imaging. In this particular case, I went to a pragmatic approach. Put down balloons, see if I can get expansion. So this is two images of a non-compliant balloon at 20 atmospheres. You can see, particularly on the right side, there is a waist in the more distal part of the balloon. This is not going to get the job done. So we have some options here, don't we? We can do atherectomy. You can use a scoring balloon, or you can use coronary IVL. I thought in this case there was some substantial tortuosity. We're up and down. There was already a modest lumen. I was a little concerned about getting a scoring balloon down. I also didn't think really a scoring balloon would work in this situation. And so the issue was Roto versus IVL for me, or use, I suppose, orbital atherectomy. I just felt that because I was able to get a non-compliant balloon down, in the safety profile of IVL, that in this situation, IVL would be preferred. So I went with a pragmatic approach. Looking back, I'm going to go back a slide. I'm going to show you the angiogram again. You really want to size your IVL balloon appropriately. This is a large vessel, you see proximal to that first diagonal. This is a substantially large diameter. So I chose a 3.5 millimeter IVL balloon. Certainly you could have imaged at this point and got a more exact measurement, but I think it's important to size your coronary IVL balloon appropriately and not to undersize it. Okay. So here is the coronary IVL balloon at 4 atmospheres. Notice that I got it down. This is actually, I pulled back already a little bit here. So despite the tortuosity and the waist in that instant balloon, I was able to get a 3.5 by 12 shockwave balloon down. This is at 4 atmospheres. At 4 atmospheres of pressure, it's already expanded to nominal, okay, nominal size. So again, showing the benefit of shockwave therapy in these undilatable calcified lesions. I then did OCT afterwards to optimize my PCI. But some interesting findings. First, in this view here, I'm in the proximal LED. You see classic fractures, multi-point fractures. caused by the IVL catheter, which is going to restore vessel compliance. So when I put in my stents, that you'll get full stent expansion. Also, interestingly, in the ostium of the LAD, you see a calcified nodule. And there's been much discussion prior to TCT about whether there are certain morphologies of calcium which are less amenable to shockwave IVL. And there's some very good presentations looking at the OCT substudy of the Disrupt C83 trial, which looked at eccentric versus concentric calcification and calcified nodules. And the summary was that the efficacy of shockwave IVL was similar, irrespective of calcium morphology. You may visualize less fractures in eccentric calcification and in nodules, but that's just because there's less calcium to fracture. But stent expansion, final minimal stent areas were similar among screws. And this shows you here, I shockwaved the proximal LAD, and you see that there is indeed a fracture at the edge of the nodule. It shows the therapeutic effect of IVL even in this lesion subset. So I used OCT to determine my DES size and diameter. I would also say, I'm going to go back, so when more is, you really see how thick the calcium was in this particular case. We had a really great case for IVL therapy. So just to be conservative, I pre-dilated with a 3.5 balloon. Now in the Disrupt CAD trial, you did not need to pre-dilate after IVL if you had a stenosis of less than 50%. There's nothing wrong with pre-dilating a little bit more. And I just confirmed the fact that I got good expansion, even in the very awesome of the LAD. Implanting a 3.5 DES here. See the balloon is expanding well. Here's my final result. Just focusing on the stent down here. I had adequate stent expansion for this heavily calcified lesion. And also I just want to focus on the very awesome of the LAD. You can still see the nodule there, but my luminal area is, my stent area is 6.3 millimeters squared. Very sufficient. Good results. So that there was some restoration of vessel compliance, and that stent did expand at the site of the calcified nodule. And this is the final results. You see on the left there, angiographically nice, consistent with the OCT. And, you saw this circumflex lesion I staged another time. And I used a pragmatic approach there because it was highly calcified. And that case, about 3 weeks, a month later, I used SC balloons only, got a fine result. So hopefully, with this summary, a couple of things can come through. Number one, if you want to take a pragmatic approach and pre-dilate with an NC, make sure it's appropriately sized. If you see a waste, you can then pull the trigger and move on to coronary IVL. And that although there are differences in morphology of calcium in highly calcified lesions, IVL therapy, at least in the data we see from the trial, is effective across the spectrum of morphologies. And I'll leave it at that, and thanks a lot for tuning in.
In terms of of all the data that was presented at TCT, kind of what were some of the key takeaways from your perspective?
So what were the key takeaways from the data presented at TCT in my perspective? I think there are two major takeaways. There's the 1-year Disrupt C83 data, which showed that the 1-year rates of MACE, TBR, and ischemic-driven target lesion revascularization were low and acceptable, single-digit ischemic-driven TLR rates in a lesion cohort of average length of 26 millimeters, highly calcified. These are really good results, and it supports the longer-term safety of coronary IVL therapy. So that's number one. Number two is the data, the really robust data from the OCT subset of that study, showing that irrespective of calcium morphology, coronary IVL restores vessel compliance and allows for successful stent implantation. In terms of what is next for coronary IVL therapy, now that Disrupt CAD 1 through 4 are completed, showing the safety and effectiveness of this therapy in stable CAD, I think where we need to go are for patient and lesion subsets that weren't studied in those trials. So particularly acute coronary syndrome, there are cases, patients come in, especially older patients, with both non-STEMI and STEMI of highly calcified lesions. So in that setting, is coronary IVL safe and effective? An important question that hopefully will be answered in the coming months to years.